What are the area that has a higher incidence of esophageal cancer? It depends on where you live on the planet. Okay? The epidemiology all over the world, there are 500,000 cases every year. Okay? And the death cases are around 400,000. So you can see that it is an aggressive and really malignant disease. And more than this is 4/5 of whoever diagnosed with cancers, they eventually die. And that's because unfortunately more than 50% of the cases they present in already advanced case that's beyond treatment with curative intent. As we said, the incidence varies geographically. You can see in this diagram on this map, okay, there are high incidence area mainly in South Asia, in some places in Europe, mainly UK, in South Africa and South America. There is uncertainty about the risk factors or what is the explanation of this. However, there are some factors that might be related, okay, such as poor nutritional status, low intake of fruit and vegetable, high temperature beverages might be involved, and they might be the main risk factors contributing to this geographical variation in the incidence of the esophageal cancer. In low risk area, smoking and alcohol are the main factors to predispose to esophageal cancer. There are two main varieties of esophageal cancer اللي هم انتم بتعرفوهم شو هم؟ Excellent. Squamous cell carcinoma and adenocarcinoma. Which has a higher incidence? If you go more toward the east, it is squamous cell carcinoma. More toward the west, it is more start the adenocarcinoma is higher. In our region, okay, we are somewhere in the middle, but squamous cell is still the highest number, but adenocarcinoma is more common than it is in the far east. Male to female ratio for the squamous is 3:2, while for the adeno it is more prevalent in the males. As you can see in this table, this is taken from the Ministry of Health Statistics, that esophageal cancer is less than 1% in male cancers, less than 0.4% less than 0.2% in female cancer. So overall, it's less than 0.5. Okay. It's uncertain whether there is hereditary factors in the esophageal cancer. However, there are specific predisposing factors to each type, as we mentioned, for the squamous cell carcinoma, high temperature beverage, nitrosamine compounds, and smoked food, red meat intake, and folate and zinc deficiencies. For the adenocarcinoma, they're more toward the smoking, alcohol, and gastroesophageal reflux and Barrett disease. Predisposing diseases that may put the patient under a higher risk of developing esophageal cancer, achalasia and caustic strictures. Caustic strictures, يعني usually it happens with children. ولد بيكون بيلعب برا، بفوت مشوب عطشان، بيشرب إشي زي المية، بيطلع هذا bleaching agent or Hybix or caustic material, so they develop caustic injury. If they survive the index event, on the long term, they need to be on a surveillance, because they are around more than 100 folds risk of developing squamous cell carcinoma in the remaining esophagus. Achalasia also has higher risk of developing squamous cell carcinoma. Prior gastric surgery, atrophic gastritis, tylosis, airway cancers, or poor oral hygiene are of the factors that may predispose to esophageal cancer as well. Okay. بشكل رئيسي الادenocarcinoma, you have to remember that it is strongly linked to the gastroesophageal reflux disease, to the Barrett esophagus, to obesity and smoking. Pathobiology, the behavior of the tumor. Do you know the main difference between the two main types? واحد بيكون من تحت وواحد بيكون من فوق اللي هم الادينو where does it start? Lower esophagus. Adeno usually tend to happen in the lower part of the esophagus because of the underlying pathology is gastroesophageal reflux, right? The Barrett usually it happens in the lower esophagus, so it predisposes that area to develop adenocarcinoma. While the SCC tend to happen in the upper esophagus, from the middle esophagus and up. Okay, that will also be reflected on the lymph node distribution, right? Okay, هلا as we said yesterday, your cancer surgery is never complete unless you take the draining lymph nodes. Okay, why do we take the lymph nodes? Because the lymph nodes are the first place for most of the cancers to land in once they leave the involved organ, right? Okay, you take the lymph nodes for better control of the disease. It doesn't make sense to remove an organ, okay, and to give the patient the morbidity of removing esophagus or a stomach or a colon without, and you leave cancer cells in the lymph nodes behind. They'll recur in a very short time. So if you want a control of the disease, you need to remove the organ, the involved organ, or part of the involved organ, and to remove the draining lymph nodes. Right? Okay? هلا in the esophagus itself, there is something different. There are two differences in the esophagus from the rest of the GI. Okay, anybody have idea how it is different anatomically? Yeah, go on. No, no, that's not the main difference. Yeah, go on, doctor. Yes, it has adventitia instead of a serosa. Serosa. The rest of the GI, the rest of the GI has serosa. Okay, and mucosa, submucosa, muscularis propria, and serosa. While in the esophagus, it doesn't have a serosa, and that doesn't help in the surgery. They have a higher risk of leak because the serosa is one of the strongest layers to hold a stitch once you do an anastomosis, right? But for the esophagus, because it lacks the serosa, they have the highest risk of leak all over the GI system. The other thing that the lymphatics in the esophagus is in the lamina propria, while in the rest of the GI they are beyond the muscularis propria. هلا عشان تتذكر هاي هلا muscularis mucosa احنا بنعرف انه في عندنا epithelium, basement membrane, بعدين lamina propria, muscularis mucosa, and then start the submucosa. هلا it makes a huge difference between the organs that the lymphatics are very close to the epithelium to the esophagus, while in the rest of the GI they are still beyond the muscularis mucosa. Okay, هلا that is reflected on the cancer by the early spread to the lymphatics. يعني unfortunately the esophageal cancer, as we said, more than 50% they present with distant metastasis or lymphatic spread or locally advanced disease. So because of this anatomical difference, they have early spread of the cancer. Esophageal cancer, they spread to 3 different fields of lymph nodes. Anyone? Yes, to the celiac, to intra-abdominal lymph node, mainly the celiac, yeah? Cervical, yes, if it is in the upper esophagus, they go to the cervical, yeah? And? Yes, intrathoracic lymph nodes along the esophagus, okay, and along between the esophagus and the trachea, along the upper part of the esophagus, supraesophagus lymph nodes. So there are, as we said, there is almost always early spread to the lymphatics, and you have to consider that there are 3 different fields of lymph nodes involved that can be involved in the esophageal cancer. هلا the other thing about the esophageal cancer that it may invade the adjacent organs like the trachea, the bronchi. Liver is a distant organ. احنا بنحكي عن adjacent organs. From the top, they may They may invade the larynx, they may invade the tumor, may invade the vocal cords, may invade trachea, bronchi, lungs, aorta, pericardium, crura. Okay, these are all the organs that go along the esophagus. That will be reflected on the presentation of the patient. هلا squamous cell usually they present as early lesion. That's why we mentioned, as we mentioned yesterday, in the endoscopy, you have to do a very careful and thorough examination of the mucosa, because early esophageal cancer, they can look like a small nodule or a subtle thickening in the mucosa, or even just like a plaque, okay, on the lining of the esophagus. Okay, adenocarcinoma, they may look like just a nodule. Okay, طبعا in advanced cases they look like a stricture or a fungating mass or an obstructing mass. Now, that is if the cancer is only in the lumen. If the cancer extends beyond the esophagus, it may invade the organs that we just mentioned. The presentation of the clinical presentation of the esophageal cancer, it varies from non-specific symptoms to dysphagia, bleeding, chronic blood loss, or even in advanced cases, they may present as recurrent chest infection because of a tracheoesophageal fistula. They may present as hoarseness of voice because of the invasion of the vocal cords or recurrent laryngeal nerve. They may present, there are varieties of symptoms that they can present with. You have to have a lower threshold to pick esophageal cancer, especially that this is not a case that you frequently use, but we still can see esophageal cancer, although this is low, but still can see cases. So you need to keep it in the list of your differential diagnosis, especially in elderly patients, because it is a disease of the elderly. As you can see in this picture, okay, you can't see a definite mass, but it's just like a plaque, okay, or thickening of the mucosa. Sometimes you may see just a nodule or a small ulcer. For the adenocarcinoma, as you mentioned, it tends to happen in the lower esophagus, okay, on a background of Barrett or on a background of esophagitis with ulcer. Lymphatic spread for the squamous cell carcinoma, if it is in the upper esophagus, they tend to spread to the upper thoracic lymph nodes or to the cervical lymph nodes. For the lower esophageal cancer, for the adenocarcinoma, it tends to spread to intra-abdominal lymph nodes, mainly celiac, left gastric, or common hepatic. For the clinical manifestation, you have always to suspect esophageal cancer, although you are in a low risk area, but still you can see these cases. Whenever the patient presents with dysphagia, think about cancer, okay? Alarming features, if it is persistent, if it is progressive, if it is associated with weight loss or anemia, if the patient is elderly, just straight away to endoscopy, okay? You don't need to waste time. Right? هلا إذا مريض مش بنقول لك إنه كل مريض dysphagia should go, it's mandatory to do endoscopy. Okay, it's better to do endoscopy, but in a patient with a low risk group, مثلا young patient, 25-year-old, has a dysphagia since 10 years, it is intermittent, it's more to liquids, something suggestive of a motility disorder rather than a cancer. بس dysphagia due to cancer, usually it's a mechanical obstruction, so it is persistent and progressive. بيقول لك المريض أنا كنت أزور بلقمة كبيرة، بس هلا حتى المي مش قادر أشربها. Usually you have to go for upper endoscopy. هلا diagnostic test, classical teaching, they usually used to start with the barium, but nowadays with the availability of the endoscopy and with the advancement in the endoscopy, with the advantage of taking a biopsy, we go straight away to an endoscopy, because it will give us, we'll have an idea, we'll have a look, we'll take pictures, and we take biopsies. Okay, so usually if you suspect esophageal cancer, you need to start with upper endoscopy. You take biopsies as well. هلا في شيء mentioned in the literature, it's called brush cytology. Brush cytology, usually it is used for screening. Where do we do screening? Screening we do in a high risk areas, such as South Asia, China, Korea. Okay, هذول areas اللي بيعملوا فيها screening they put a sponge connected to a tube. It's just like a capsule. The patient swallow and then you pull it up and you take whatever cells on that, you put under the microscope and you identify whether there is a cancer or not. It is not available, it is not used, and we don't have screening program for esophageal cancer. And alhamdulillah, we do not need a screening program because we have a very low number of cases. But in the cases where do they screen for esophageal cancer, they may use the brush cytology. هلا, whenever you suspect a cancer, you assess your patient. How do you assess your patient? Huh? Yes, excellent. يا شباب خلينا نتفق من هون لحد ما تتقاعدوا. Okay, how do you assess whatever? It is history and physical examination. Okay. The history حكينا symptoms, alarming symptoms or the features that would be suggestive for a cancer, for esophageal cancer. Physical examination, what do you think? إذا جاك OSCE case for a patient with suspected cancer, do a focused exam. What do you examine? Yeah? Yeah, okay. Your second point is the right one. يعني swallowing هو المريض نفسه بيحكي لك إنه عنده dysphagia بس in real case scenario or in the exam, if you're asked to examine a patient with suspected cancer in the esophagus, you have to start with the general look of the patient. General look. What are the things that we look at? Cachexia. If they have cachexia, signs of recent weight loss, okay, that's number one. Number two, if they are pale because of chronic blood loss, if they are jaundiced because of possible involvement of the liver, okay, and then you examine. What do you start from the top down? What do you examine? الدكتور اللي حكته الدكتور زميلتكم, you examine the cervical lymph nodes, supraclavicular lymph nodes, you listen to the chest, okay, and you examine the abdomen for organomegaly or suggestion of liver metastasis. So that's the examination. And then once you complete your history and physical examination, if you confirmed the cancer, you need to know the stage of the disease. You need to know the stage of the disease to decide what is the best treatment for this patient, okay, and to know the prognosis, the possible prognosis of this case. What do we use for staging? Usually we start with a CT scan, pan CT or chest, abdomen, pelvis CT, okay. Do we do a brain CT? Yes, we don't do it routinely unless the patient has a neurological symptoms, okay, neurological deficit or a headache. We do a brain CT. Otherwise, we start from the chest, abdomen, pelvis CT. If it is upper esophageal cancer, you start from the neck as well. Okay, you do the CT. The CT, what does it show? If there are distant metastases, if he has liver, lung, bone metastasis, okay, it will show up on the CT scan, right? Okay. Does it give any information about the cancer itself? No, it will give ليش لو. Yeah, it may show you enlarged lymph nodes. It may show you thickening of the lesion itself into the esophagus. It will also show if there is invasion into adjacent organs, right? These are all information. How do we conclude the stage of the disease? Excellent. TNM. We need to know the T. What do we mean by the T? The depth of the tumor. Excellent. The depth of the tumor into the wall of the esophagus. Okay, it starts from the TIS, okay, to أول شيء T0 ما في tumor. T inside to اللي هي above the bit, localized to the epithelium, okay, or intermucosal cancer, okay. بعدين بتروح على 1, 2, 4, right? Okay. هلا هذول you can tell from the CT scan. والN اللي هي lymph nodes, number of the adjacent lymph nodes involved. الM هي 0 or 1. يا عنده distal metastasis يا ما عندوش distal metastasis. Distal metastasis mean involvement of an organ that's not adjacent to the tumor, distant organ, right? هلا هذه السي تي. EUS. Did anybody witness an EUS or see an EUS being done? كل ثلاثاء بيعملوا بالجي اي unit EUS. It works to have a look, to have just to have an idea about this, because you'll hear about this in the next few years a lot. Okay? EUS هي endoscopy, but there is an ultrasound probe at the tip. So it gives you an accurate information about the depth of the tumor. Depth represent the T. بتميز لك between T1B, T1A, T1B, and T2, 3 till 4 and 4A and B. اوكي. هلا الاي يو اس عاده احنا السي تي تبين الاشياء الكبيره differentiate between T3 and T4. but من T intramucosal cancer or TIS لحد T2 you need the EUS to know which layer, because intramucosal is something localized to the epithelium. You can't take endoscopically ولا بتغلب المريض لا بكيمو ولا بعمليه. Okay, if it is T1A بتشيله endoscopically. Okay, بشغله اسمها EMR, endoscopic mucosal resection, right? If the endoscopist tells you that this is most probably T1, most probably T1B or T2, you need to do surgery, right? فالاي يو اس كثير مهمه. وهذا سؤال امتحان انه the most accurate test to identify the T stage of the disease is the EUS. هلا هون EUS and CT بعطيك up to 80% accuracy of the depth, وبعطيك more than 80% accuracy of the end stage. الاندوسكوبست بيقدر يحكي لك انه في lymph nodes هذول involved or not because they can see, right? هلا there are another advantage of the EUS that they can take. If there is an area with suspected involvement of the cancer, you can take a needle biopsy. You can, under the ultrasound guidance, you can take a needle biopsy from that area to see whether it is involved or not. هاي الرسمة راح تشوفها بكل الجي اي. اوكي. يعني tumor localized intramucosal cancer or intramucosal high grade dysplasia, it is in situ. T1 انتم شايفين اللايرز هون. T1 is something above the submucosa localized to the mucosa. اوكي. هلا في عندنا الميكوزا اللي هو epithelium, basement membrane, lamina propria, muscularis mucosa. بعدين خلصت الميكوزا. ببلش عندك submucosa, بعدين المسلز, بعدين الادفنتيشن. اوكي. PET scan. Okay, what do we mean by PET scan? Positron emission tomography. Okay, why do we use it? Excellent. Because the CT scan will tell you if there is a distant metastasis or not, but if the lesions are less than 0.5 centimeter, okay, they are highly unlikely to show up on the CT scan. So you need to do the PET scan. It is more accurate in detection of metastasis. Sometimes the CT may raise a question rather than giving a definite answer, and you get the answer from the PET scan. يعني بيقول لك الراديولوجيست والله هاي اللي باللنج مش عارف هل هي fibrosis ولا هي metastasis مش عارف. Do a PET scan. You do a PET scan. If it lights up, okay, it goes with the metastasis. If it's not, it exclude the metastasis. So the PET scan is a mandatory part. يعني احنا قلنا endoscopy to diagnose, EUS for the depth of the tumor and the N, CT for the metastasis, and PET scan to confirm whether he has a metastasis or not. TNM شوفوا هذا دائما كان يعقدني وانا طالب. اوكي. بس اذا كل مره عن مره with the help of a chart تحفظهم سهلين يعني. اوكي. شو تي اي اس اللي هي high grade dysplasia tumor localized to the mucosa. T1 اللي هو بس بالميوكوزا. T1 اللي هو above the basement membrane TIS. okay, localized to the epithelium. T1 بالميوكوزا. T2 involving muscularis propria. T3 involving beyond the muscularis propria but still didn't leave the esophagus. T4, it is divided between T4A and B, right? Okay. هلا T4A involving adjacent structures pleura, pericardium, and diaphragm. T4B, again, it involved adjacent structures. But what are the difference between A and B? Huh? Excellent, excellent. A, that you can involve, this is an adjacent organ, but still you can take it out with any block resection. Any block معناتها to remove it with the cancer. With any block resection, and the patient can still be alive, right? B, you can't take the aorta, you can't take the bronchus, you can't take the trachea, okay? So that's a deal breaker or a game changer. يعني انت عندك اي شيء T4 T4A and above T4A من هون وتحت okay with whatever N and M0 can be a patient with that can be treated with a curative intent. يعني it is not a deal breaker. هلا شو الاشياء اللي هي deal breaker for surgery؟ T4B انه بقدرش اعمل له عمليه or M1 excellent ممتاز أو M1 anything other than that if they are fit enough they can go for surgery right. هلا you have to stage the cancer. احنا هلا شوفوا اللي هي stage 1 whether A or B يعني ما فيها N اوكي او ال T less than 2. هلا stage 4 once انه صار عندك M1 with whatever T whatever N بس يصير عندك M1 خلص we're talking about stage 4. In between it depends on the T stage and depends on the N stage. Right? هذه بتعطيك prognostic idea how much the 5-year survival of the disease. هلا selection of operative candidate شوفوا the primary modality of treatment of esophageal cancer هي surgery. في ناس they can be treated endoscopically اللي هم الناس اللي هو only localized to the epithelium or localized to the mucosa اللي نحكي عن T1A right. T1A يعني there is no invasion into the submucosa right. هذول T1A تقدر تشيل التيومر with the endoscope بشغلة اسمها EMR endoscopic mucosal resection okay. هلا بس تصير T1B there is an invasion into submucosa which means there is invasion to the lymphatics which means the tumor has already arrived reached the lymph nodes. You can't treat with the endoscopy only because endoscopy only doesn't reach the lymph nodes. You can't take the lymph nodes. So we're talking about surgery. T1B and above, we're talking about surgery. Okay? هلا surgery with chemotherapy, surgery without chemotherapy. Okay? Anything less than T2 who needs surgery, you can go straight away to surgery. T2 and above, it is better to give chemotherapy with the surgery. ماشي؟ اوكي؟ يعني هو السؤال هل المريض is the patient fit for surgery or not? Does the patient need surgery or not? هذا next question. And the third question, does the patient need something else with the surgery such as chemotherapy or radiotherapy? هذول الثلاث أجوبة. مين اللي ما محتاج عملية؟ اللي هو T1A or less. مين المريض اللي بتروح عليه عملية على طول هو T1B. مين المريض اللي محتاج عملية مع كيموثيرابي أو راديوثيرابي T2 and above. Right? Okay? ماشي. Yeah. Distant metastasis because once the tumor has reached a distant organ, it means the whole way is involved with the cancer. يعني هي الفكرة إنه العملية شوفوا هاي off record. العملية it's a major operation. Okay? It is a major operation and I worked with a senior consultant who used to tell the patient that this is a very big operation. It is similar to be hit by a bus. Okay? يعني المريض كأنه he had a major crash. Okay? It's a major operation. So you don't put the patient through a super major operation, okay, if the outcome is futile. If you're not looking for a good outcome. Okay? So if you put the patient through a major surgery, there has to be something that a good outcome that you're looking for. Once it is this, once there is this metastasis, the 5 year survival, whether you do an operation or not, is dismal, right? Okay, so leave the patient in peace rather than in pieces, right? Understand? Okay. هلا مين المريض؟ اذا قلنا ان المريض هذا بده عمليه، is he fit or not؟ هلا you can notice that this is a disease of the elderly. Still can happen in the youngs, but the most of the patients are the elderly patients. It happens in the 6th or 7th decade of life, right? Okay, usually they have comorbidities. Usually they are knocked down already with the malnutrition if they have a long-standing dysphagia. They are sometimes they may have pulmonary cardio or pulmonary diseases. Your patient should be strong enough to go through a surgery. Your patient should be optimized if they have any medical condition, right? Okay. In general, squamous cell carcinoma, you can use. There are different guidelines. There are American guidelines, there are Eastern guidelines, there are European guidelines. In our country, we follow the European guidelines. In general, squamous cell carcinoma, you treat with either two options. Either chemoradiotherapy, and that's it. This is called definitive chemoradiotherapy, okay? And it gives a good result, depending on the stage. Or you can give chemoradiotherapy followed by surgery. That will be a neoadjuvant chemoradiotherapy. which is which؟ يعني إذا إجاك مريض عمره 80 سنة عنده COPD, okay, but still he has good functional status, you can give chemoradiotherapy alone because he's not strong enough to go through a major surgery. إذا مريض عمره 60 سنة بروح على الجيم 3 مرات بالأسبوع, he can withstand surgery, you go for chemoradiotherapy to be followed by surgery. ماشي, because it gives a better outcome. But still, the definitive chemoradiotherapy, you need to give this option to the patient because it gives a considerably good outcome. هذا بالsquamous cell carcinoma. بالadenocarcinoma, okay, they usually do better with the chemotherapy alone. Okay. هلا احنا كيف بنحكي الاشياء هذه؟ من وين جبناها؟ This is evidence-based medicine. Evidence-based medicine based on trials. Okay. In the last 10 years, there was massive changes, massive development in the treatment of the esophageal cancer. في عندك trials معروفة, في عندك cross trial, في عندك magic trial, في عندك flood trial. Okay. هم هذول اللي based on that they see which one would achieve the highest 5-year survival. Okay. هلا indicators of unresectability, non-unfit patient. Okay, patient who wouldn't tolerate chemotherapy or surgery, or M1 disease, or T4B. Okay, they're beyond treatment with a curative intent. ماشي. هلا lymph nodes, para-aortic or mesenteric lymphadenopathy, هذول although they are lymph nodes, but they count with the M1. ما بتعدهم بالN. ليش؟ Because they are non-regional lymph nodes. التيومر اللي وصلهم على المسافة هذه, this is M. هذه مش لأنه draining lymph node. This is called non-regional lymph node, and this is called M1. Okay, this is one of the other indicators of unresectability. هلا esophagectomy, okay, في عندك type. Primarily, you need to remove the esophagus. Which part of the esophagus? If it is adenocarcinoma, you remove the lower 2/3 of the esophagus. If it is upper esophageal cancer, you remove the whole esophagus. Once you remove the esophagus, you need to replace it with something, okay, to restore the continuity of the GI. المريض بده ياكل في الأخير, right? Okay. هلا whatever you replace the esophagus with is called conduit. Okay. It can be stomach, it can be colon, it can be small bowel. Most commonly used is the stomach. you pull it up. Okay. Where do you put it? Either posterior mediastinum or substernal or subcutaneous. There are technical details that you don't need at the moment at your stage يعني. This is a picture of a procedure called ايفر لويس. ايفر لويس هو اسم الجراحين اللي عملوا هاي العمليه اول شيء. تحط المريض على جنبه او تبلش المريض supine position. You go into the abdomen, you mobilize the stomach, you tubularize the stomach, okay? And whenever you move an organ from its place, it needs to be based on a pedicle. لأنه ما ينفعش إنك بدك تطلع المعدة من البطن توديها على الchest. It needs, what does it need? It needs blood supply عشان تعيش, right? Usually this conduit is based on the what vessel? Excellent, ممتاز, right epiploic. Right epiploic, because to move it, you need to cut the left gastric, you need to cut the short gastrics, okay? And it's usually based on the right epiploic artery. Okay, you pull it up into the chest after you remove. يعني العملية كيف كنا نسويها؟ إنه المريض بنبلش هذه في عندك if you remove the lower 2/3 of the esophagus, it's called two-stage esophagus. Two-stage إنه في عندك stage بالabdomen, يكون المريض نايم على ظهره, okay, supine position. You start either open or laparoscopic. You go in, you mobilize the stomach, you do lymphadenectomy at the celiac, left gastric and common hepatic. You mobilize the lower esophagus. الشباب اللي حضروا معنا عمليات شافوا كيف we mobilize the lower esophagus from the mediastinum through the abdomen. Okay. بعدين بنخلص بنسكر البطن. Stomach is already mobilized. Okay. نحط المريض على جنبه. Either we go thoracoscopic or thoracotomy. You mobilize the esophagus, you resect the lower 2/3 of the esophagus, and you pull the stomach up to join it here to the remaining part of the esophagus. This is called two-stage esophagus. إذا كان عندك three-stage esophagus اللي هو in the squamous cell carcinoma, you need to remove the whole esophagus. بتبلش من الchest, you mobilize the esophagus from the attachment, okay, and then بعدين بتحط المريض على supine position. واحد من الجراحين بيكون بالبطن وبلش mobilizing the stomach. واحد من الجراح الثاني بيكون بالneck, okay. They dissect the esophagus, they leave a cuff of 2 to 3 centimeters just below the pharynx. بعدين transect the esophagus from here, it's pulled through the abdomen and then pulled out, given as a specimen, and then you pull the stomach up to the neck. هذه اسمها 3-stage esophagectomy. 3-stage esophagectomy called McEwen esophagectomy, هذا اسم الزلمة يعني اللي بسويها. و Ivor Lewis esophagectomy اللي هي 2-stage esophagectomy. Right? Technical details I don't want to know about it. Okay, just have a general idea about it. Okay, the main thing, the take-home message we'll summarize in a minute. في شغله اسمها Sievert classification you need to know. For lower esophageal cancer, they're called junctional cancers because they are close to the gastroesophageal junction. في واحد اسمه Sievert, he classified the tumor according to the site into 1, 2, or 3. If you consider a line passing in the middle of this orange zone, the 0 line or a Z line, the gastroesophageal junction. Between 1 to 5 centimeter, okay, above the Z line, that's Sievert 1. Between 1 and 2 centimeter below, that's Sievert 2. Between 2 يعني تحتيها 2 سم لحد 5 centimeter, that's Sievert 3. شو بهمنا؟ 1 و 2 they're treated as esophageal cancer. يعني you need to do esophagectomy. 3 they usually behave as gastric cancer. You don't need to remove the esophagus. They usually have extended total gastrectomy. That's enough for them. Right? As we said, lymphadenectomy is essential mandatory part of any cancer surgery. Okay, with the esophagus, there is always airless spread, almost always airless spread to the lymph nodes. The lymph nodes, they usually spread it all over 3 fields: cervical, thoracic, and abdominal. chemotherapy and radiation زي اللي حكيت لكم إياهم. Palliation, unfortunately, you frequently need palliation with esophageal because more than 50% they present with the case with advanced stage of the disease. You can't treat with the curative intent. You treat only with palliation. What do we mean by palliation? Yeah. We treat symptoms. يعني if the patient asks you احنا يعني عادة تقدرش تحكي للمريض especially if they are elderly إذا الأهل بيطلبوا أو شيء. It depends on your setup, okay? But if you want to be open and honest with your patient, you tell them that we're not aiming for cure this disease. We're not able to cure this disease. However, we can improve your quality of life. If they have dysphagia, you put a stent, okay? If they continue to bleed, you do a chemotherapy, okay? A radiotherapy. If you want to slow the growth of the tumor, you give a palliative chemotherapy. Palliative chemotherapy, I mean a lower dose, okay? We're talking about quality of life and a bit of longevity of the patient. They may live, if you slow down the tumor, they may live a little bit longer, okay? That's the palliative options of the disease, right? Okay? Any questions? Yeah, go on. Yeah, unfortunately, that sometimes this is the case when you cannot replace the esophagus, or if you replace the esophagus, يعني بتصير حالات مرات you replace the esophagus with a conduit, okay, but it dies out. The stomach, the whole conduit will become necrotic, okay. The patient is not fit to use another conduit. يعني let's assume that you use the stomach became necrotic, okay. The patient is not well enough to undergo colonic transposition, okay. You just perform a spit fistula for the saliva. It's called esophagostomy. Spit fistula, colostomy basal bag, and the patient will be dependent on some other mode of nutrition, either a TPN or you put a feeding jejunostomy, okay, which is much better than the TPN. Yeah, unfortunately, that is the case with some patients. Any questions? Thank you. Take care.